How are you?
I have his LinkedIn. Can you show his LinkedIn? But it's awkward, probably because he'd have to stop you. So don't worry about it.
Let me see if we start. I think we could. On our end, we could, but he would have to stop sharing.
Yeah, the way this put this.
Okay.
Okay, so we'll give one more minute just to make sure everybody comes that's going to be coming. Hope everyone had a nice week. It's Friday, so let's see these big smiles. Yeah, that's right. Thumbs up. Hope that you have a nice weekend too. And all right, well, why don't we go ahead and start? We'll be recording. It's a real pleasure to introduce to you our guest speaker. Jawad is a friend and a colleague. He's also one of the key editors in the new book that we're writing called Modernizing the Global Health Security Agenda. From Pakistan, he's in Pakistan now, so it's like 10 p.m. I want to thank him, or 11 p.m., 10 p.m. or 11 p.m. I want to thank him for staying up late to give this presentation. And we also share, Jawad worked he was in the Epidemic Intelligence Service program like I was. So he's been very, very well trained and established the field epi training program in Pakistan. And so it's a very interesting, yesterday you heard, and Wednesday you heard about India's experience with public health surveillance and COVID-19. And now we're going to hear about Pakistan's experience. And I like his subtitle of his, you can go to his LinkedIn page and find out more background information on him. And I will share his email address as well. Of course, his title is Chief Executive Officer of the Global Health Strategic and Strategists and Implementers is a company now. And we work with him on a variety of other projects as well. It's a real honor to have him present to you, because it's important for us now to learn from the pandemic and to design and think about how we can improve public health practice in the future. And Jawad's a key person to help us understand that. So we'll go ahead and, Jawad, thank you very much for coming. It's a real honor to host you here, and it's all yours. Go ahead.
Thank you, Scott, and it's a pleasure. As you said, I was your neighbor at CDC campus for 2 years in my EIS assignment. So Emory is a good place. And actually, when I wanted to do Masters in Public Health, I was accepted at Emory University. And I was impressed with their logistic information, which I got in Pakistan, in which I was told that I will have a room, someone will pick me from the airport, and that will be my phone number. So they sent me my personal phone number before I was going to arrive there. So I was impressed with the logistic arrangements at Emory, but somehow I decided to go to University of Washington instead. And that's another story. But Emory has been, I know because I applied there and was accepted, that's a very good university. And once I came to CDC, then I had more opportunities to actually, once co-teach a session which our department used to teach. And maybe you may know it, Scott, it was our TV department used to give some lectures here at Emory a long time ago, but that's how I'm very fond of Emory. So now let's come back to the topic, which is COVID-19 and Pakistan. And when I was making this presentation, I thought let's put a teaser there that how a developing country did better than the USA. And just to make sure that pandemic is still going on, contrary to many. I think we still have some time to go with this pandemic. So it is premature for us to decide which country did better or not. But I'm focusing on on the initial phase of the pandemic in my presentation today. So before we start, and I know you are working on, you are paying attention on surveillance. And I remember, and this is one of my favorite quote of William Foggy. I'm sure all of you are aware of his name and his work. And he said very nicely that the reason we collect any information about disease, uh, it's the whole purpose of collecting that information should be to control the disease. Not just by the end you publish a very nice article or a nice surveillance report and share it with other stakeholders. If you are not focusing, the information you are collecting is not linked to how you're going to control the disease with that information, then you should, that's not a good practice, and you should allocate those resources to somewhere else. So in public health, it's not academic exercise just to know about the disease. We should always link how we are going to use that information in minimizing morbidity or mortality of that disease. So give you some background on Pakistan. Pakistan has a population of 220 million. 40% is urban and 60% is rural. But we have some of the major disease burdens, including tuberculosis, in which we are the 5th largest disease burden country. For hepatitis, we have more than 12 million patients or cases with hepatitis B and C. And the disease surveillance systems, different disease surveillance systems have been evaluated as fragmented, vertically oriented, and dependent on external funding. That was the situation when we came. And when I said we came, US CDC came to Pakistan to set up a Pakistan Field Epidemiology and Lab Training Program, which is a sister program of Epidemic Intelligence Service of the CDC, of which both me and Scott are graduates. So if you look, and this data is like 10 years ago. So if you look at disease surveillance system in the country, there are, more than 24 systems were there, but none of them was collecting good information. But there has been major push to set up disease surveillance systems in the country. And one of the first one was health management information system, which was set up by US aid in 1980s. But then for some political reason, it was stopped. The whole process was stopped, and the surveillance system was gone. The other one was again set up around 2000, which is we called disease early warning system. This was set up by WHO, and USAID also funded it. By the 2005 or 2007, when I joined Pakistan Field Epidemiology Lab Training Program as CDC resident advisor, DUES has already finished its funds, and they wanted it to hand over to us. But again, the whole project, which expanded to, I think, nearly 70% of districts in Pakistan by 2010, eventually in next few years, pretty much, became a skeleton of its previous past. Similarly, DHIS was supported by Japan aid agencies, and that was also in 2000s. Pakistan has AFP surveillance, which is acute flaccid paralysis surveillance, which is done for the polio work. And this is a very, heavily resource intensive exercise. And there are a lot of global supporters of this program. So when Pakistan FELTP came onto the scene in 2006, very early, we thought that if we just trained people in epidemiology and didn't have a career structure in the country, or relevance of their work is shown on to the government, very quickly the government will lose interest in this whole effort. So from the start, we not only just started a training program of epidemiology, we started working on disease surveillance systems, including response systems. This project was funded initially by USAID, and then I think we were able to get secure funding from US Department of State, CDC, HHS funding, and again, Pakistan federal and provincial governments also funded the program by supporting their fellows. And just to give you a difference, in other FATPs countries of that time, it was a US CDC who was paying salary to anyone who will come for this FATPs training. So in Pakistan, we were one of the few countries which started that government is going to pay much of the financial resources also of this program, and it will not be exclusively donor funded program. And then even though we started IDSR through FELTP, later CDC became less interested in IDSR, and that has been picked by, even though the design of the program was by us, FELTP and CDC, US CDC, now USAID and UK aid is actually supporting that activity. So nearly all disease surveillance systems lack response component, and that's a major issue. And data was not regularly analyzed, and data is not available for decision making. No feedback to the field. The people who collect the data, they will never get the field, and data is not shared. And remember this, data collection is not disease surveillance. I'm sure you know by now that if you collect the data on disease, that's not disease surveillance system. It should be linked to the public health action. It should be linked to the feedback to the people who are collecting that information. Only then the quality of your information will improve. Otherwise, you will be collecting information which will be not useful, not trustworthy, has no relevance. It will not be used for decision making. And once it's not used in the decision making, there will be no resources by the government for that data systems. So as soon as our fellow, we trained enough people, we started what we called disease surveillance and response units in Pakistan. And that was part of Pakistan's sustainable event-based surveillance system. They were notified in all 4 provinces and in federally administrated areas. That means Islamabad, major provinces, and some provinces has more than one. And they were, by the time I left in December 2018, we had 11 operational DSRUs. And the concept of DSRUs was like this. Student will come to our Islamabad for FELTP training. And after 2 months, we will send them back, not to their districts, but to their provincial capitals or DSR, where in the beginning DSRUs were set up. They will work under the direct supervision of Director General of Health of that province and help him in disease surveillance activities and respond to any outbreaks. And that's how we were able to negotiate with provincial governments that provincial governments will fund complete running of those units from their own resources, including travel for the outbreak investigation by these fellows, the whole logistic. Until that time, it was always WHO or other donor agencies who were paying for these outbreak investigations. But once these fellows showed their worth to the provincial health departments, provinces were so keen to send their best people to us for training and utilize them for all the outbreak investigation, because they were bringing good name to the provincial health managers. So when I said 11 operations, so we had actually one which was set up by the Pakistan Army also, because for I think 2014 onward, Pakistan FELTP started training military persons in our training program, Navy. They were all medical backgrounds, but people from Navy, Army, they were part of our regular cohorts. So with this help, because they were doing most of the outbreak, nearly all of the outbreak investigations, the timeline of response got better. Because in many instances, as soon as the outbreak was discovered, the team will go within few hours, because in Pakistan, there are more than 100 television news channels who are hungry for news, and they're looking for this outbreak. And the government got a great resource where people who are trained in epidemiology, field epidemiology, could be on the ground within hours. So that was very helpful. And because of their work was now being accumulated, we started a weekly activity report, or weekly FLTP outbreak investigation report, which we thought will be the MMWR of Pakistan in the future. And so this was a weekly report, just a few pages of report, which has outbreak investigations, which they have done, fellows have done, or surveillance reports. And it was regular in its distribution, that every week it will come on time. It was shared broadly, not only in Pakistan, but also across the world. And WHO was actually, they later told me that this is the only disease reporting publication which is coming from not only from Pakistan regularly on a weekly basis, but from our region. So the hope, so the issue was that by doing this, we will have a sustainable disease reporting system. We also started, I think, 2014 or even earlier, we added veterinarians also in our regular training program. So Pakistan FATP is one of the earliest programs in which we utilized the full One Health concept when people were not talking about One Health yet. So our fellows were medical doctors, they were veterinarians in the beginning. Later we added dentists also, just like expanding the qualifications of the FATP. So this was the whole organogram which we envisioned, and the blue circles or squares or rectangles are the structures which were working by the time I left. The yellow part was that we wanted to add, and or either we were working on it. So that was whole linked system of not only training, but also a disease surveillance system which will be sustainable by the home country. Through these fellows, they did some outstanding outbreak investigation. And if I look on just 2 or 3 years of data, more than 300 outbreak investigated. But important, the bullet in whole of this slide for me is that 95% of all costs was paid by the government of Pakistan, either federal or provincial. This is very difficult to achieve. If you are a donor-supported program, you set up something in any country, and then you expect government to pay, whatever the percentage of that cost. Major outbreaks we have done, and I want to mention 3 diseases. One is Candida auris. This was first identified in 2009, resistant to all 3 major antifungals. Fatality rate is 60% approximately, difficult to eliminate from hospitals, and risk factors. Pakistan, I think, was one of the first 6 countries in which Candida auris was identified, and we were doing an outbreak investigation thinking this is something else, and later we were told from the lab that no, this is some new disease which is Candida auris. And I think the Pakistan is the first country to do a match case control study to identify risk factors of a totally new disease. And for those of you who have interest in infectious diseases, I just tell you, this is a fungal disease which simultaneously appeared in like 4 different continents or 4 different areas, which are distinct to each other, but they all evolve around the same time. So there is, some people think that this is due to um, environmental pressures, which change a fungus which normally does not hurt to evolve into something very new. Second one is the XTR typhoid. That means extremely drug-resistant typhoid. This is the largest outbreak in the world, which happened in Pakistan, and we investigated it. We identified the, let's say the area X and how it spread. And again, I think 2017 it started, and by the end of 2018. Our estimation was that the 40,000 people have been infected by it at least. So that was a very good study. And I think one component of it we presented at EIS conference in 2019, and my fellow got the first prize in the international night in Atlanta. The third one is Naegleria fowleri, not a new disease, but it's an amoeba which lives in clean water, and we investigated largest outbreak in Pakistan in 2014 to 15, and we were able to interview relatives because this is nearly 100% fatal. There is only one case of survival, and that's, I think, in US. So we were able to, our fellows were able to interview relatives while patients were still alive. That show how good the surveillance system was set up in Karachi, where we investigated disease by our fellows. So over the years, by the time pandemic came to Pakistan FELTP was doing pretty much all the surveillance work or all the outbreak response work by the government of Pakistan. Either, there are at some provinces they were stronger, and some provinces they were not being utilized. But overall, it was FELTP fellows who were doing most of the surveillance and outbreak investigations. I have just put this slide for your information, and I will not discuss here, but you need to remember this, that public health response when governments demand when a pandemic comes cannot be generated in an instance. For that, you have to work over the years on epidemic investigation, laboratory practice, surveillance, and also invest on basic infrastructures of workforce capacity, information and data system, organizational system. So when governments or the leaders want why we don't have this public health response so quickly or so better, you need to remind them that you had to invest on these essential capacities and the basic infrastructures for decades, if not at more than this. So now coming on to the today's, let's say, the teaser or something, that how in COVID-19, US and Pakistan performed. And the reason I picked this area, that I was able to be part of the initial response of COVID-19 in Pakistan. So these two, the graphs just show you in like raw numbers, what have been the waves and the number of cases in US and Pakistan. As you have noticed that the scales are different. US, the peak is at something like 800,000. Pakistan peak is around 7,000. US had like 1, 2, 3, 4 maybe waves. Pakistan may have like 5 or 6 waves. It depends on, these all waves. They can manifest up and down because of many reasons. So let's see. These are the daily new confirmed cases, COVID cases per million people. And as you know, all of you know that when we are comparing countries, cities, we have to use, the population denominator just to make sure that these numbers are comparable. But if we look at this graph, we see Pakistan pretty much on a straight bottom line, while US has, quite peaks and higher number of cases per million of population. So people can, argue, and I do argue also this, and I agree with this, that there are many limitations also. Pakistan still didn't have enough tests per person. We didn't have tests in the beginning, enough tests to test. So if you are not testing, you are not going to declare anyone of COVID-19 patient. So these were the limitations. But even with this limitation, the stock difference is huge. So many people always say that you can hide cases, but it's difficult to hide deaths. Sometimes people do hide deaths, but if they are at a higher scale, it's very difficult to hide deaths in any country. People will take, everyone has smart cameras, everyone is online. So it's very hard to hide graves or bodies. They show up. So then once we look, and again, this is per million population, these are not raw numbers. We see Pakistan has done, even if you consider all the underreporting or, the limitations, much fewer number of deaths. But when we look at vaccination, single dose or one dose, Pakistan and US, Pakistan has done pretty well, considering it's a developing country. It does not have resources. It does not have the infrastructure which the US had. But it's still able to manage around 50–60% of people. Even though it started late, it got the vaccines available to the population much late. But he has done a pretty good job in doing those single dose vaccination. And if we look at completed vaccination also, the initial regimen, they are again, there's a difference between US, but again, Pakistan has catched up pretty, I would say, impressively. But one thing which bothers me is the case fatality rate. And in this, I have India, Pakistan, and United States. So India and United States had a higher case fatality rate in the beginning, and with the time it improved, and it's now less than around 1%. Pakistan has stayed around 2%. Now it's less than 2%. But that, for me, I have raised this issue many times, that it's not possible that you have a straight line like this of case fatality rate. Again, that reflects on data, issues, and the way we count our deaths or the number of cases. So that's a red flag for me. But again, if we go back and look at this, no matter of underreporting can hide the bodies. So now another important lesson, I'm sure again you are aware, that when we look at a graph, and I always tell my students, don't just pay attention to the headlines, read the whole news, because headlines sometimes does not give you the real story. So if we look at US completed vaccination, it's a very good number, and we should be confident that we are okay. But if you start looking at states, then you see there is a huge variability. Some states at around 50% and some are 80%. So when we are planning at a national level, we should not be consumed by this graph. We should ask for this graph. And if you are a state epidemiologist, you need to look at each county graphs. And I can tell you that one outbreak investigation I did in south of USA, I will not name the state. The state was doing very well on the TB control, or their TB rates were better than even US national rates. But when we looked at one county rates, we went into under the state and start looking at different counties graphs, what we realized that one county has like 3 times, 4 times the national value of numbers of the US national numbers. So always go for the smaller geographic location to see what is brewing there, because that's how you will pick outbreak which can potentially become an epidemic and then eventually pandemic. So always go, try to, don't be happy with this slide, try to go states and then even at different major cities data and look at them separately. And that reminds me that I have talked about this issue a lot, that when you are trying to control a disease or a pandemic or an epidemic, don't make decision based on national data. Each city, you have to fight those fights in each city at each county level. Look at the data at the lowest administrative level, make decisions there. You cannot have a one uniform decision based at a national level, which could be effective at every level. So you need to follow a grand strategy of things, but still make a decision based on your localized data. So now the story of COVID-19 in Pakistan, how it started. I was paying attention on a new disease. This is my sort of interest that looking for new outbreaks. So I was following that story that new pneumonia cases are being identified in China. And then I saw this news that I saw I think at the night of January 14th and 15th in between, and where the first case outside China has been identified. By that time, only one person had died and 41 cases were identified. So I wrote a message to the federal health minister, who was a friend, and also I had assisted the government in the last dengue outbreak in Islamabad, which was a major outbreak. So I sent him a message and I said, Dr. Zafar, this is a new disease, and it has now spread beyond China, even though there is only one case. But that shows it can come, it can be an international disease. So I suggested him that we should have an interprovincial health meeting in which we alert provinces about a new disease. That's all. That's how it was. I remember this was very early on the 15th of January. He agreed. And I think we started discussing this. And by, I think, 22nd of April, we had our first meeting of what we called at that time a Federal Core Committee for Novel Coronavirus. At that time, it was not called COVID-19, so it was called Novel Coronavirus. And me, similarly, WHO's Pakistan lead and other people from different ministries became part of that new committee. We started meeting on a daily basis, and its membership expanded in coming days. But it was a daily meeting. It was a new outbreak, so I was writing about it also. But and sometimes when I mentioned 1918 pandemic, some readers actually were not happy about it, and they said, "Are you crazy? You are saying this will be like a 1918 pandemic?" But there were worries for me, and this, I think, this was published again by the end of January. And as you know, when we write for newspapers, sometimes we write it like week or 2 weeks in advance, and only with time the newspaper publish it. But we were worried, even though the cases were limited at that time, mostly to China. So if we look at how fast things moved, that China reported cluster of pneumonia cases of unknown origin on 31st December 2019. And the seafood market was closed on 1st January. Then the good thing was that very quickly a new virus was identified on 7th of January. This is like really advanced analytics. And first death was reported on 11th January. And first case outside China was found in 13th January. And 15th, sorry, and 15th January, Pakistan started high level, as I mentioned, those meetings, consultations. And on 23rd January, Wuhan was put under quarantine very quickly. Everything happened very quickly. So what was the difference in Pakistan? And I will talk about the US response at that time. The good thing which happened, and it was by chance, it was not by design, that the new federal minister of health who was a public health professional from WHO. So he was, and I think he joined like a year ago, just a year ago, and he was requested to leave WHO and come back to Pakistan and help Pakistan health system. So, and he agreed. And he was also a close friend of mine. So I had, we had a very good communication. So Federal Core Committee of Novel Coronavirus was formed, which was a formal committee, which was spearheading all the control strategies for a new disease for which we have limited information. It was all different government ministries, including Army, Civil Aviation, Defense Forces, all those kind of health departments. But the good thing was that they added, they inducted 3 independent scientific advisors. So, I was the field epidemiologist, even though I was inducted as infectious disease advisor, communicable disease advisor. Then we have 2 very good clinical infectious disease consultants. One later became the health minister also. So basically, for the whole pandemic era, we had 2 very good, well-trained public health experts leading Federal Ministry of Health. That was not by design, that was by chance, but that helped us a lot because as a public health professional, I didn't have to convince them. They speak the same language and we understood each other very well. And core committee started to meet on a daily basis and made early decisions to prepare state health system for this pandemic. Sorry for the misspelling. So until the first case, so we started this work on 15th January and so we didn't have any case yet. But we started, alongside health minister, I was another semi-official spokesman for the government on coronavirus. So I was also on the media explaining a new disease, why we should not get panic and follow basic public health principles. And as a public health professional, I was worried about a society strict with panic, because we have seen and taught about this, that when any epidemic or pandemic or outbreak create a panic, then even if you have resources, people cannot utilize them because they are running from one place to another. So we made it very clear to all stakeholders that remember, at that time if that becomes a real pandemic, we need to ensure that we control the panic. We should discourage all those activities which create panic. So screening of airline passengers started, even though I didn't agree that 95% of our the resources were going through improving the border security and airline passengers screening. I was very clear that you cannot stop infectious diseases at borders. It doesn't matter how many times you scan them with those thermal scanners. Once a disease will come, it will eventually come to your place or your country. And so you need to have a backup plans that if those cases come to your country and you identify multiple clusters in multiple cities, how your system going to react. So that was more important. But even with the public health backgrounds, the political pressures was so much that the ministry was more focused on screening airline passengers from China. And and our first cases came from not China, but from Iran. and that's another story. So before the first case, we had developed national guidelines, shared with them. Preventive strategies were shared repeatedly on media, and government departments were alerted. So we got a good 1.5 months before we got our first case. Our first case came on 26 February 2022, and they came from Iran, as I said. So that even though I had warned this in high-level meetings that we have to ensure there is no panic, but panic came. And as I said that I was alongside minister, I was the other semi-official spokesperson on the technical area from the government side on COVID-19. Every TV channel I was going there, the other guest was saying that the sky is falling, people gonna drop, will start dropping dead on the streets. And very senior level people will call me and ask me those questions. And I tell them that even though this is a serious, but I don't think, because I knew how outbreaks, go up and come down. These are the natural phenomena. It's not the end of the world phenomena of any infectious disease. And early data, the good thing was that China shared data early and a good quality data through, I think, Lancet articles, which helped us, people like us who were looking and trying to make policies on a limited scientific information for our own country. So I was very clear, this is a serious, but it's not end of the world scenario. Then we looked at different countries' numbers and came up with the projection. Because if you remember, in the beginning of the pandemic, epidemiologists were not being called to help governments. It was disease modelers, both in US and in UK. Imperial College prediction, and in US, there were different groups, including IHME group, and they were predicting very, I would say, crazy numbers. I sat down with one of my colleagues and we looked at the worst case scenario for Pakistan and a normal scenario. And the worst case scenario, we thought at that time, it was, I think, Italy in the initial cases, or the New York cases. And at that time, we also realized that the age is a major factor in how you come out of this disease, like what are the serious consequences are this. And we put those numbers, and that's what I'm telling you, because you should not be shy away that you cannot do this, some fancy computer language you don't know, or fancy statistical analysis. We did just simple math. We looked at the case rates, we looked at the which population, what is the demographic distribution of different countries, and apply that information on our own demographics on the case rate. And we came up with the worst case scenario and a not so worst case scenario. And we realized that it's not end of the world. So we were confident on our strategy that we need to buy time until we have more information. And there is no need panic, but panic was there, and I had to face it. People sometimes will laugh on me, and they say this guy is crazy because he's saying it's not end of the world, while everyone else, and mind you, none of them were epidemiologists. None of them has ever done an outbreak investigation in their life, but they were very confident that they know how this disease will progress and how the world will end. And when we tell them that our own experience is different, they will not believe me. But my job was to go to different news channels and pacify or answer those questions. At that time, then I wrote, where are the epidemiologists? Because I looked at the global level, and I realized that not in most countries, I would say, it was not the epidemiologists who were developing the strategy to control the disease, including USA. USA, we didn't see CDC persons on upfront. And CDC is one organization which for 70 years was preparing for a pandemic. That was what we were doing it. Epidemic Intelligence Service, it's all about outbreak investigations, how better to control a disease. But none of the people who formed the pandemic response in USA had any experience in outbreak investigation or outbreak control or disease control. They are very well respected infectious disease, I would say, researchers who have done extraordinary good academic work, but none of those people have ever done a single outbreak control in their lives. So I made an argument that if you have never fired a bullet, now you are a journal of a war, planning a strategy of how to, fight with your enemies. That's not doable. But that happened across the globe. And there is a reason for that happened all across the globe. And maybe we will touch on it if you have a question later. So then again, as I said, for me, it was important because we have limited information and we were making the strategy for Pakistan, that how to learn from the disease progression from those countries where the disease came before us, like US. I think in US first case was, I believe in January, somewhere end of January or something. So they were 1 month in advance. So another good thing I should acknowledge, the very good website where CDC provided no data, no helpful data, no helpful information, but the private sites were very good in providing helpful data. And one site which, most of my graphs are from this, our word in data, I think that's the website, and excellent, modifiable graphs I could make using what I want to know about it. A lot of flexibility. So that was very helpful. So I looked at how disease progressed in US in first, after the first cases, that was 37 day when I tweeted this. And I looked at it and I said, once they had 100 cases, US is behaving very differently than Pakistan. People didn't like it. And people said Pakistan does not have enough tests, Pakistan does not have that. And I said, that's fine. But not comparing of USA today, but when it reached 37 days, and by that time, it was doing only 50% of testing of today. And that's why I made a point that Pakistan, because people were panicking. So I said, Pakistan disease is not progressing the way USA, and this was 37 days. So these were very early time period when people were not committing, and actually there were very few people like me who were saying, you will be fine. It's a serious disease, has a global consequences, but it's not end of the world scenario also. So the whole purpose was that we need to take care, but it should not be panic. Very early also, and if you look at the date of this, my tweet is April 5, 2020. And actually, even before that, it was data from China, which, which for the very first time showed that 6 meter difference is meaningless, because they published a study in which COVID was transmitted from one house to another house with no direct link, but the ventilation was the same. So, and I had worked at CDC in tuberculosis elimination, and we knew the ventilation is critically important to decrease the spread, even though TB is a droplet infection, but still, excuse me, but if you, improve the ventilation, you can decrease the transmission tremendously. So from that background, and from April 5th onward, I was one of the, I think in the beginning, in Pakistan at least, the only advocate who will talk always about open your windows, open your doors, have a better ventilated space. It will improve, it will decrease the transmission. So what are the major differences in the early phase? I think I'm not going into much detail, but I think there were 2-3 major differences. In Pakistan, as I explained, it was public health leadership leading the control effort. In USA, it was not the public health professionals leading the control. Pakistan set up a coordination mechanism very early because no one was listening to Ministry of Health. So we brought in military, which is again has a more people listen to it, and eventually a new setup was formed, which was NCOC, National Command and Operation Center, with were military dominated. So once they will send someone to a department, they will listen to their direction much more keenly. Third, Pakistan, even though we had just Pakistan NIH at that time and very few organizations, but they had the major role in the whole process. The whole data was being collected through FELTP fellows who were trained by FELTP, and they were working in polio. And through the polio surveillance also, so on a daily basis, it was active disease surveillance system. So there were people were tasked to go to different hospitals, get the information about the COVID testing and the COVID cases, deaths, etc. So in the beginning, we had a very good data flows. And CDC, on the contrary, was on the sidelines, and I believe still is on sideline. So what are the other factors of Pakistan improved performance, which has nothing to do with our good work? And I think the biggest was that Pakistan as a population has much younger age. So even though if they were infected and we didn't know, they had less chance of dying as compared to population. And just to give you an example, US and the Europe had, I think, what is the average average? There are, I think, 25% people are above 65 years of age. In some countries, it's 20%, some it's 25% in developed countries, where you saw 80% of deaths. In Pakistan, it is, I think, less than 4% are above 65 years. So from start, this was a huge, let's say, this is not something to be proud of, that we have a younger nation and people die before reaching the, the old age. But that helped us in COVID-19 mortality. The other thing which people have not discussed, but I'm a big propagator or advocate for this, that majority, and not about Pakistan, but most of the developing countries, nearly all the population live and do business in open airs. Centrally air conditioned buildings are very few in most of the developing country. So that was another big plus, that we had a good ventilated spaces to do business, and the indoor spaces where nearly all the transmission happens, that were fewer. The third one, there were more acceptability of expert opinion advice. And again, these are social reasons for that. But later we had problems also in Pakistan that, as I said, it became dominated by administrative and political figures. So then non-technical and political leaders were making public health decisions, like USA. And political phase, was upfront instead of expert talking about pandemic control strategies. Heavy-handedness in identifying context, because when you bring in military, police force, and all those law enforcing agencies, instead of the way we were finding contacts for any disease, infectious disease, they will send a police contingent to the house of suspect case, and then they will bring in, and that created a lot of bad blood. And I think Pakistan couldn't recover from that lack of trust. Even now, people stopped going for testing. They didn't report to the system, and just opt for no testing. And they will tell doctor, okay, treat me as a COVID-19 patient, but I will not have a test. So plain and simple this. That create problems with then our whole data surveillance system. So questions, have we learned any lesson? And are we better prepared for the next pandemic? And I will leave these two questions for you, because I don't think that we have learned any lesson. And I don't think that we are better prepared for the next pandemic. Write down those if you want to know more. But before I leave, I thought I should give a way forward also. It should not be pessimistic. There are ways how to improve things. And one thing which I'm propagating for quite some time is the health intelligence. And, people talk about it, health intelligence. We have a health intelligence hub here and there, but they are not treated as health intelligence hubs. I want them to go beyond ordinary disease surveillance system, and they should be funded and operational at par with the country's other intelligence agencies. And I make the case, every country invests heavily on their intelligence systems, military intelligence system, whatever their intelligence systems, because they want to know that an enemy will not harm our country. So that's the whole purpose. But now we have learned that, this non-human thing, virus or bacteria, can sometimes do more damage to your country than your neighbor, an enemy who may be your neighbor and want to attack your country. So this virus or bacteria are more dangerous than human enemies. But we do not want to invest at the same level which we invest on, human enemies. And I think these need to be changed. So that's only then we will have the best people, and we need to have people who have the same mentality of an intelligence agency agent, who want to see results quickly, they do not work 9 to 5. They work for their tasks. So the whole mindset need to change. Only then we will have a better protected countries or the world. Again, this is also part of this, that national security. If you do not invest on health security, your national security is not complete. And actually, I wrote this article before the pandemic, or I think the early phase of pandemic maybe. And it says, and actually, let me see. Yeah. So it was published in February, earlier February. So it must be written like 2 weeks in advance. So maybe, and that was a gaping hole in national security. The other thing when we talked about surveillance system is, especially when we are talking with donors or funders who want to invest in it, they always count the cost of surveillance separately, and they do not add response into it. And then for them, it's not cost effective to have a surveillance system, unfortunately. And I have been to many international consultations where we are trying to get funding for one surveillance and another, and people think, oh, $2 million is too much. But benefits of a surveillance system are dependent on the response system which is linked to it, because then you can show that because we got this information quickly enough, we were able to do something, avoiding so many premature deaths or the economic loss. And a lot of people have done a lot of good work on it, which is published. Then another myth is that, public health didn't do well because we didn't have money. But I think that's a myth. It's not the money. Money will not solve all the problem. Problem is how the leadership over the years have evolved to lead public and global health. And most technical, and just before pandemic, most of the technical leadership of international or national organization was replaced by those who have more experience of finance and management than public health good. And that's why I wrote, with minimal on-ground field experience in outbreak controls, they were like generals who never fought on the ground. And that was the key problem. People at the top never did an outbreak management. They never did an outbreak control. They never went into the field. And now, I think in one of the review of CDC, I think the reviewer has put those few things on the paper, which we identified much earlier, that the promotion at CDC should be based on your impact on the ground, not on the how many paper paper you have published in high index journals. In public health, that's good, but that's not good enough. For our fellows, our students, we always ask them to, when they write a report, an outbreak investigation or a surveillance evaluation, whatever, we ask for the impact. Has their work made an impact, and how they have measured that impact? So that's important. And this is, I like this quote. I found it a couple of months earlier, but I love this, that I shall try not to use statistics as a drunken man uses lamppost for sport rather than for illumination. And this is Andrew Lang, Scottish poet, novelist, and literary critical. And the reason I'm giving you, especially in epidemiology, because it's about numbers, sometimes young epidemiologists are carried away by seeing some numbers. Always, look under the numbers, see how these numbers are being calculated. Only then you will understand the full magnitude of the message you are trying to pick from that numbers. So always go deep. Just don't look at the superficial. Always ask how you collect this number. Tell me more about it. Only then you have understanding that these numbers are good or trustworthy or not. I will stop here so that you have like 20 minutes for question. Thank you.
Yeah, thank you very much, Jawad. Thank you. Yeah. And someone with Scottish history, I appreciate that statement there. Okay, we have some questions, I'm sure. Actually, there's one in the chat. I think you can read it for one of our colleagues. Can you read it, Jawad?
Did you find it helpful to decrease panic by sharing more information, details, or less information? Yes, that's a good question. The question is that how you were able to decrease panic by sharing more information or holding on to information. CDC has developed what we call the risk communication strategy for the health crisis. And it's part of regular FETP curriculum. And every year I will, this was my practice, that I will teach that component myself. And it talks about all those things. And it says for those crises, it's important that you should be the first one to share the information. You should be the truthful. Only then people will believe you. So what we try to do, at least while I was part of those early months, that we will not hide any number. Every number should be shared as soon as possible. And my students were collecting that information by 7 a.m. in the morning. We had like a report of last day, how many people got infected or tested in each city or each province, and how many are hospitalized. That was expanded to how many are in high pressure oxygen, how many are on ventilator, how many died. And this was shared on a daily basis. So that helped. And then later the government made it even much more bigger. And it not only helped in reducing panic, but it also helped in coordinating. That when I think in the Omicron wave, I think it was third or fourth wave, we were close to 80-90% of our hospital capacity, bed capacities. That was, I think it was bigger than first, second, or third waves. And because all this data was available, so the health department could direct people not to go to this hospital, but go to that hospital, which has few ventilators or emergency bed or oxygen, high pressure oxygen beds available. So that helped to decrease panic and also Because if you hold on to, you do not share the information, then all the rumors start and you won't be able to control those rumors. So always share truthfully and be the first one to share that information, because it's late, then no one cares about your numbers.
Very good. Thank you. Other questions? Okay, anybody? No. You're passing the microphone. Please introduce yourself.
Hello, I'm Heba. Thank you so much, Dr. Ajgar, for the fruitful information. I just have one question regarding the sentence that we can't hide deaths. Actually, I come from a developing country. I'm from Egypt, and COVID deaths were counted from the total COVID positive people only. And I know that in certain rural areas, people may die in their houses due to COVID and not knowing about them. So how you dealt with such situation or such limitation? Because in my country, it was a very huge limitation in counting COVID deaths. Thank you so much.
No, this is true pretty much everywhere. And as I said, once in our country also, police was being sent to people's houses to pick the suspected cases and sometimes separate the families. Like husband is going to one hospital, the wife is going to other, and the kids are going somewhere else. People stopped, coming to the health system. And then there was a stage when I said, okay, these numbers are now meaningless, because if people are not opting for testing and those numbers are not being reported, which are multiple times of the actual numbers, then the value of numbers goes down. And I think the health department should be upfront that setting up of a disease surveillance system, even for COVID-19, should be done properly. In the beginning, that was okay, that we were collecting, and I have said this many times, that collecting everyone who is in hospital for COVID-19, it's not disease surveillance system. You should come up with some case definition. You should have a suspect case, whatever case. And then even if you are covering 10-20% of the population, we can intelligently guess about the full disease burden for the remaining 80% of the patient. But the way the haphazardly the numbers are counted, and I'm saying not just Egypt, across the globe, especially for COVID-19, all these numbers have lost their value for quite long. And now I see those numbers just to make see the trend and see how things. Maybe I do not ever think that I'm seeing a full picture. This is just one component now of much bigger picture, and I need to fill in the gaps from the other information sources. That's sad, but still most of the COVID-19 surveillance systems across the globe are not proper disease surveillance systems.
Okay, good. Other question, please.
Thank you for your lecture. It's very interesting for us to know what's going on in Pakistan. My name is Maya, and I have a very short question about your laboratory system and how you're able to detect the virus, how quickly, and how many % of people able to be detected in the beginning. Thank you.
So in the beginning, nobody had lab tests, so that was a problem. So, and I think we got the first sort of test from China, something, and these were limited in numbers. But within 1 or 2 months, we had enough tests, and we started with one lab in Pakistan which was doing tests. And I think within a few months, I think 15-20 labs, like all major labs in Pakistan, started those tests, and they were all government labs, and all these tests were free. So that was a good thing. So that's why I said the initial data from Pakistan is much more reliable than the later data which came afterwards. But in the beginning, we knew how many tests we had, and they were being utilized. But then sometimes in the beginning phase, sometimes the number of tests we had were fewer. So you need to deploy them very strategically. But that's why I said most of the countries didn't have proper surveillance system in which you don't need to do 100% test. You could have syndromic, what we call suspect cases, probable cases, and confirmed cases, and you can come up with the limited tests also, but have a better picture. But nearly all countries relied on those PCR tests in the beginning before the rapid test came, and that was true also. But very quickly, the lab services were expanded, and then private labs started to add on to it also.
You mean like you don't use from the beginning PCR test, right? Just only snap test?
No,
And,
no. In the
also
beginning, it
PCR
was
test.
in the beginning it was only PCR tests.
Only
Actually,
PCR.
rapid tests were added much later because the government was not in favor or didn't consider rapid test as a reliable test.
Okay, thank you.
Okay, any other questions?
Okay, so first thing is, mine is a comment, like commendation, and the second one is a question. So honestly, I want to commend the team in Pakistan, because from the way you're speaking, I could feel the political will. I could feel the prioritization of the health of the Pakistan population. But unfortunately, my name is Kende from Nigeria. I was part of the public health, team in my institution back home that responded to COVID. So I saw the other side of the story. I saw whereby a decision whereby the political will was not there, or was either wavering. But again, we responded with limited resources, and leadership was not too good. But on the long run, I think the community also played a very good role. So Pakistan, with what you've given us, I think leadership is very strong, and they did well. So my question is, what problem do you have with the modeling as regards emergency risk communication this time, but the COVID-19 risk communication? What's problem do you have with it? Because I tend to have a different opinion about it. So I wanted to share more light on it. Thank you, sir.
Thank you. And if I understood your question correctly, that what are the challenges we saw in risk communication? Is that the question you asked?
Yes, you highlighted that when you were giving us a lecture, that you didn't subscribe to what the CDC and other global health agencies were doing in terms of modeling for the COVID-19 pandemic.
yeah.
So I wanted to get more insight into why you didn't agree with that.
So my problem, and I will come back to CDC issue, but and I have been very vocal on it also, even when I was part of the core committee, that we didn't have a real good expert on risk communication. And we had people on communication, and people believe that if a Federal Ministry of Health sends a directive through media, newspaper, television channels, or radio, people should follow. And that was sort of a communication strategy. And that's not the communication strategy. And you have to work with the communities. You have to come up with a common strategy, and share with them what are the risks are, and then come up with those what we call SOPs, or standard operating procedures, or precautions, which then they can implement on themselves. Most of the advices were generated, and I was part of those, sitting in Islamabad, and we are coming up with a strategy for shopkeepers, but none of us is a shopkeeper. We didn't consulted with shopkeepers, and that's how then those strategies are not implementable, because the people don't accept it. So I think the whole understanding of risk communication is not understood very well in many areas, including Pakistan. On the CDC part, is the risk communication strategy, I think, is pretty good for the basic. It's not, it's just like a small part of the overall training, but it tells you that you cannot lie, number one, with the community. and you should not hide the numbers. You should be, because if you do any one of those things, you will lose trust. And you cannot control a outbreak or epidemic if the community does not trust you. Remember, as a doctor, sometimes we have a paternalistic view and we think that we know best for the communities. But if you are in the field, very quickly learn that by that mindset, communities don't take your advice very well. So you have to work with communities to come up with the solutions which are applicable to them. And so that should be your part of strategy. But if you lose your trust by lying, by hiding, or by what the other thing is, in public fighting of the experts with each other, then communities don't trust, and then you have all the problems.
Assalamu alaikum, sir. My name is Hina. I'm from Pakistan also, and I'm veterinarian. Thank you so much for such information, and it's marvelous for Pakistan, I know, and I congratulate you on this. I have a question, like, how do you think, like, when pandemic came and the public responded to that, especially with the rumors and all the things, like public followed the procedures and the recommendations and the advices from the government, and also, like, what are your comments on it? Like, thank you.
Before we had the first case, as I said, we had a very high level meeting where very key stakeholders sat down. And there I raised to this someone who controls media in Pakistan. I said, if the pandemic comes, just make sure one thing, that we do not have panic. But panic came once, because again, remember, we were getting reports from New York that how the dead bodies are being put in freezer. That was the earliest pandemic issues. It was New York, it was Italy. These were the two places, because China was able to control its news. So we didn't know what was happening. But in Italy and the New York, a lot of dead bodies were lying on the streets, or they were in the deads, and they were on the media. So that made people very much afraid. And I think the counter strategy was that we were on the media and trying to answer the question as truthfully as we could, with the limited information we had at that time. And I remember these were the days when I was running from one TV studio to other, and the third one, the fourth one. And when in the prime time, there was a few days in which I was on 4 major channels simultaneously. 3 had recorded me earlier, 4th was doing live, but they were broadcasting at one single time. So that was the media exposure we had to go through. And before that, we didn't have that experience or expertise in that. So we learned it very quickly on our way, because that was the one way to tell the public what is reliable information and what is rumor. And most of the time, these were like talk shows, and I have to respond to those rumors, which unfortunately were being propagated by medical doctors with no public health experience. They were clinicians, or they have doing the other backgrounds, but they were well respected in their fields. And some were scientists, some were, again, they were not illiterate people. They were well respected part of the society in the country. They had their positions, but they decided they have to make projections on a pandemic for which they never had an experience. So I had to respond to those questions. But I think overall, by not hiding, keeping, being truthful, and being available to media helped in an initial phase Pakistan avoid panic.
Very good. Thank you so much, Jawad. We have one more question. I know it's late for you too.
No,
so-
that's fine. That's fine. It's a weekend, and I know that normally I would have been watching a movie at that time.
Well, the next time you're in Atlanta, we want to take you out to dinner for sure.
Sure. I would love to go.
Hi there. My name's Ajay. I had a question sort of regarding Pakistan's, like the administering of information with respect to Pakistan's cultural dynamics. So I'm sure like Pakistan is also a very culturally diverse nation with like provinces like Punjab and Balochistan and Sindh and whatnot. I was wondering, like, one thing we talk about in global health a lot is how we sort of deal with like cultural humility and the administering of information while sort of taking the cultural context into account. When you were dealing with COVID and with public health surveillance and communication of information, is like cultural differences or perhaps like maybe different languages? I know Urdu is mostly widely spoken in Pakistan, but like were different cultural dynamics something you had to consider when it came to like dealing with administering of information?
Yes, and I think that's true everywhere. And in Pakistan, there are different languages like Pashto, in the Sindhi, Balochi. In some areas, it's the Persian, which is spoken. So a lot of different languages. And public health messages were created very quickly in the earlier phase. And some were in local languages. So if you are there, you will get that message in the local language. But the pandemic information was shared mostly in Urdu language, and then it was translated by different groups. So in that time, I was not only speaking in Urdu, but in some channels I was speaking in Punjabi, which is my mother tongue also. Similarly, many of my students who are from all the provinces of Pakistan, and they speak, Balochi or Pashto or Sindhi, so they were speaking the same message in their local languages in the local television channels. So the languages were different languages were used, but I think that the other thing is more important is the cultural context of the different regions. And for that cultural context, I think it's more important when we are collecting the information. And once we are giving them advice. And the good thing was that over the years FALTP program of those 12 years, we have trained really more than 200 good quality field epidemiologists who were spread all across the Pakistan. And they were at the at the mid-level positions in most of the provincial department of health. And in the initial phase, most of the COVID work also came to them. And that was helpful that we all knew the same language. They were trained by us, and that helped a lot in the initial phase.
Okay, great. Thank you very, very much.
My pleasure, my pleasure.
We'll share the recording with you too. Thank you so much, Sean. All right, well, everyone have a nice weekend. Please smile and do acts of kindness. We need that now in this world for sure. So
Okay,
have a
thank
nice
you.
weekend.
Bye-bye.